I'm Becky Simmons, and along with Dr. Eamon Chen, we are the directors of the Children's Environmental Health Center at University of Pennsylvania and the Children's Hospital of Philadelphia. Our center is called the Philadelphia Region for Research in Children's and Environmental Health. So I thought that this is great for all the people who have joined us. And it's my pleasure to introduce Neela Grimsley, and she is at the Grady College of Journalism at the University of Georgia. And she's the program coordinator for the translation core of their center, which has a very nice long name, Children's Health Assessment, Research, Translation, and Combating Environmental Racism, called Charter Center. And in this role, she has been coordinating recruitment efforts and data collection at each of the project's YMCA after-school sites. She manages the logistical and admin aspects of the project and provides support and oversight to the graduate students. She got her master's in public health from the University of Georgia and her degree in child and family development, public relations, also from the University of Georgia. We're really excited to have Neela talk to us today in our efforts to better translate what we know and are learning in our own research areas and arenas to the community and to the public. So, Jessica, if you want to amplify or add anything, let me know. Go ahead.
Well, we're excited to have this be the first part of two parts on talking about communication in children's environmental health as part of the sort of first jump off partnership with one of our fellow centers. We have centers across the country that started under the same NIEH grant funding, stretching Oregon, at USC, in Atlanta, and up in NYU. So this is just the first opportunity of the first conversation between two different centers, and hopefully there are more to come on various different topics that stretch across the country. So, Neela?
Awesome. Well, thank you both for that introduction. I'm going to share my screen really quickly, see if you guys are able to see my slides.
Yes.
How are we looking? We're looking good? Okay.
Yeah. Great.
Wonderful. Well, welcome everyone. As Becky stated, my name is Neela Grimsley, and I am the program coordinator for the Charter Translation Core. I work with Dr. Grace Ahn at the University of Georgia, and she is the deputy director of Charter, along with Dr. Linda McCauley, who is the director of the Charter Center at Emory. Now, Grace is also the translation core lead, but she wasn't sure if she was going to be able to make it today due to travels and airport Wi-Fi. And so I will be giving a quick introduction to Charter, who we are and what we do, and then I'll also introduce our speaker. So to get us started, Charter is part of the network of environmental health researchers and centers, along with the University of Pennsylvania, funded through the National Institute of Environmental Health Sciences. And so one of our primary overarching aims for Charter is to effectively translate impactful scientific findings related to children's environmental health with the goal of reducing environmental racism and enhancing the health of children. So within our translation core, we take scientific findings related to children's environmental health, and we break those findings down into understandable, applicable, and actionable messages using our health literacy expertise on our team. And so we'll also be leveraging the storytelling power of virtual reality with individuals and healthcare providers to promote and sustain lasting change among underserved communities in the Atlanta area and beyond. And to do this, we have a wonderful interdisciplinary team of folks from Emory University, UGA, the University of Georgia, and Spelman College. And we bring together extensive expertise in environmental health, communication science, health literacy, and community engagement. So the Charter Center is excited to be here as co-hosts, and we are even more excited to kick off this series with a communication scholar from right here in Athens, Georgia at UGA, and her name is Dr. Soroya Julian McFarlane. And Dr. McFarlane is an assistant professor in the Department of Communication Studies at the University of Georgia. She received her PhD in Communication Studies as well as a minor in Public Health from the University of Miami. But before joining faculty at UGA, Dr. McFarlane was a practitioner in health communication and worked in governmental, non-governmental, and even international organizations such as the WHO. And so her research focuses on designing and evaluating communication interventions that address health disparities, primarily at the community level. Dr. McFarlane's research is driven by understanding how culture influences health and also how communication interventions that translate science for diverse populations might be effective in reducing health disparities. So Dr. McFarlane is also the PI of the Conscious Lab. Am I saying that correctly, Dr. McFarlane? Awesome. Which facilitates dialogue with underserved communities to design and evaluate interventions that promote health. So all very, very exciting work. And we are thrilled to have her here with us today to talk broadly about health communication and skills that we can use to be more effective in communicating children's environmental health with diverse populations. And so with that, please join me in welcoming Dr. McFarlane, and thank you so much for being here.
Thank you so much for that kind introduction. Let me share my screen. Are you able to see that? Okay, yes. Great. All right, this afternoon I'll be talking about communication skills for children's environmental health. And you just already heard a great background on the Conscious Lab, a little bit of it, and I'll show you kind of a little bit more of what I do. But for the most part, I'll talk about a couple of communication skills that might be useful in integrating in children's environmental health interventions. From what I understand, my task is to kind of pull back the curtains on the role of communication science to address children's environmental health. So I'll do that with a couple of examples from projects that I've worked on, and then of course open it up for questions. As you heard, my lab is called the Conscious Lab, and it stands for Communication for Community Health and Shared Understanding of Science. And we focus on facilitating dialogue with underserved communities to design and evaluate interventions that promote health. For the most part, we look at health disparities within the US as well as outside the US. So comparing populations within the US to understand differences in health outcomes and the role of communication to make a difference, as well as across cultures. Why are there those differences? I also am curious about big picture methodology questions, such as what's the best method for interacting with communities. So these are some of the areas that we focus on in our lab. Today, we will mostly look at my home country context of Jamaica to understand kind of how we can apply communication science to inform formative research that is the foundation of planning for interventions for these types of populations. And I always kind of start every talk and every time I teach with kind of these imperatives for health communication, and I don't take credit for them. This is from Dr. Viswanath, and he suggests that the imperatives of health communication is 1, to translate scientific information, to use the appropriate format, language, channels, and then to make that information available to all, regardless of class, culture, background, geographic location. So that is always at the forefront of what I do. In terms of communication skills, if you're trying to translate this science for different audiences, regardless of where they're from, and using the optimum tools available, or the appropriate tools that are available, it's important to understand tailoring or targeting. And I have to throw out a question to you guys, and that is, what do you think is targeting and what is tailoring? Is there a difference? You could just drop it in the chat. Let me know what you're thinking. What's target? Is there a difference between targeting and tailoring? We use these terms interchangeably. What from your perspective is, I'm looking at the chat, and if you want to speak, you can also take a moment and quickly say. Is there a difference? So somebody says targeting specific group, tailoring messages. Anybody else want to venture a guess? Anybody want to say? Okay, I'm not gonna take too much time. I'm gonna go into it. So I'll use this example from this 90s campaign. I don't know how many of us remember it, but it was called, my students certainly don't remember it, but it was called the Verb campaign, and it was quite popular on Nickelodeon channel, right? And so the idea is that targeting is group level data, right? If you're targeting an audience, the audience is largely homogeneous, or should be, right? So the Verb campaign, they had a general audience that they targeted, and you could see some of the images there associated with what we might think of as just general American kids and their parents. So targeting uses kind of the approach that we're sending messages out to a largely homogeneous population that has shared background, shared values, etc. Right? Now, tailoring wants to account for the individual level, wants to customize and personalize messages. So we want to understand, usually by using a survey or some kind of big data or computer-based mechanism, we want to collect the data at the individual level to understand what are people's personality traits, values, anything that would inform their behavior. And we want to tailor messages at the individual level so that we want to customize. So it's highly personalized, it's highly customized messaging strategies. Now, in health communication, we don't often have that big data. Walmart has it, Target has it, and that's what they're doing. They're tailoring things that they send to you via email. So what we end up doing in health communication is actually tailoring by creating subgroups. So for the Verb campaign example, they tailored to 4 audiences. They chose sub-audiences of the general American population of kids and their parents. So they did ethnic tailoring. They had African Americans, Hispanic, Asian, and American Indian parents as their children, and their children as target audiences. What they did was that they had separate strategies for ethnic minority population, and then they hired ethnic agencies, or what they call an ethnic agency, with developing mini campaigns for each ethnic group. And the agency would conduct a full range of formative evaluation, testing the concepts and messages for advertising, and developed separate messages for its ethnic group. They tailored the visual imagery and the language using different channels, right? So for example, for the African American kids at the time, they thought Little Bow Wow was a great role model. And they said that from their formative research, they found that the product would have to reinforce coolness and make it seem like it was uniquely for them. So this is a campaign that encouraged movement among kids. And you can see the first image here. This one was for American Indians, and the one to the bottom left was for Hispanic Americans. And they had a different tagline called Ponte las pilas, or get your batteries on, get moving. So they tried to tailor at that level to specific subgroups. So again, targeting is a general population thing, largely homogeneous. Tailoring you try to customize based on individual level data, okay? And in order to do either tailoring or targeting, we have to do formative research, either qualitative research involving focus groups, interviews, to explore communication norms, how people prefer, what the channels people prefer, the tones and the formats, or quantitative research to understand the means of some of these things and how to culturally tailor for these target audiences. And we always pre-test the messages to make sure that what we put in as an intention is actually perceived by that audience before we launch that campaign. So what I'm going to do is show you an example of how we use theory to inform formative research to target the Jamaican, to hopefully, design an intervention to target the Jamaican population. So in this study, we wanted to understand cultural factors influencing teenage pregnancy in Jamaica, which is at almost double the rate of some of the populations here in the United States. And we know that this rate is linked to culture, but there hadn't been enough research that explicitly made that link. So we used theory in order to understand what was at play and how was it linked to culture, and then understand what should the health communication intervention be for at-risk girls, girls at risk for teenage pregnancy. So we use this model called the PEN3 model. And the first dimension of this model is a model that centers the role of culture in health behavior. And it's a little bit different from the kind of typical public health psychology theory that we typically use because of that central role of culture. Culture is also seen in this theory as a positive thing, an opportunity for health intervention, as opposed to how we normally frame culture or how we've learned to frame culture as a barrier. In this theory, culture is an opportunity and a positive thing. So in the first dimension of the PEN3 model, which includes these 3 domains that you can see on the screen, the first dimension is cultural identity, which includes the person, the extended family, and the neighborhood. And the person is the individual whose health is in question. So for example, that's the adolescent mothers or at-risk girls. The extended family would be relatives and friends, and the neighborhood would be anybody in the community that influences the practices. The cultural identity is always the entry point for intervention to address a health concern. And the point of entry can be those individuals like the parent, friend, or teacher, or communities that are best suited to introduce that intervention to the population. The second dimension is the relationships and expectations dimension, which includes the perceptions, enablers, and nurturers. And then the third dimension is the CE, the cultural empowerment dimension, which may have positive, existential, and negative attributes as it relates to health behavior. These are qualities of a culture that influence healthy behavior, but some of them, like the existential attribute, may not be necessarily positive or negative. And I'll give you an example of that. So what we did was we took the literature that exists and we used the taxonomy to create a coding scheme based on the transcripts that we got from, well, based on the literature, first of all. Then we also validated what was in the literature with field work. We went to the field, we had focus groups with adolescent moms, girls between 14 and 18, who actually had already had babies. And we asked them about some of these related questions that had to do with the theoretical framework. And we placed everything into this 3x3 matrix that included the domains of the Pen 3 model. So you can see the first pen here, the second pen along the top, right? And then how it works is that you put the third pen in the middle, which is the person, extended family, and neighborhood community, right? So we were able to have what was already existing in the literature. Then we went to the field, collected the data, and were actually able to see if these were still the factors affecting adolescent pregnancy. And we were also able to extend what was existing in the literature based on this method. So for example, if we zoom in just a little bit, how it works is that you then kind of cross the matrix. So you can say positive perceptions. What are the positive perceptions? So we found that, again, as came out of the literature, there was this resilience among adolescent girls in Jamaica, that this is a positive cultural attribute where the girls felt that they were able to bounce back from this negative life occurrence, and that this would be something that they would always do. So there was this optimism, and there was this resilience. In terms of like a new finding, we found that as an existential perception, which is a perception that may be neither positive or negative, some of the girls admitted that they were actually happy to some extent that they had families at a younger age for a variety of reasons. They said that they were healthier younger, they were preventing future infertility, and that they had the opportunity to enjoy life by the time they got to 30 and access career opportunities then. And any of us who have had kids late, after 30, you'll know that, you can't fully argue with some of the reasons that they came up with, which is why it's in this existential category. Because yes, we do not want early pregnancies, and we recognize that tends to, on the bigger picture, hold the girls back and perpetuate a cycle of poverty. But at the same time, they weren't totally wrong in their viewpoint of some of the advantages of, so to speak, getting it out of the way. So there were these existential perceptions. Now, the point of this exercise is for us to see how to understand particular audiences and use this understanding to culturally target these audiences appropriately. So from our perspective, we don't ignore pop culture, but we actually use it as the basis to directly address myths, misconceptions, and provide alternatives and other opportunities in terms of messages as well as structural interventions that can create behavior change. So we use the Pen 3 model to confirm and extend these factors, and then create a picture of this uniquely cultural phenomenon. And from that, we were able to find the entry point for cultural targeting, through which we suggest should be through the girls themselves. They said they want to be a part of future campaigns, so we suggested a participatory approach to interventions. And you can see more about that, the suggestion there and the entry point for intervention in the publication in Culture, Health, and Sexuality. So that was just an idea of the formative research that we do to inform targeting messages. Now, again, this is targeting because we recognize that this was a largely homogeneous population, Jamaican girls, a specific age group with pretty similar values and shared background. Now, another important communication skill that we employ a lot is message framing. And while I can't get into a lot of depth about message framing, I thought I would also share how we use cultural targeting to use a popular or a common version of message framing, which is fair appeals, right? And fair appeals have you know, gotten some in some ways a bad rep, right? So I wanted to ask you, what do you think are fair appeals? This is something that's very communication centered, and you can drop it in the chat again or use the mic. You can feel free to jump on. But what is a fair appeal? If anybody wants to quickly say. Using fair as a basis for suggesting positive behavior change. That's from Jessica, yes. I'm going to continue just for the purpose of time. So fair appeal is manipulating, or is a part of message framing, which is manipulating how information is conveyed in a message, how that information is presented, usually for a persuasive purpose. Somebody also said an example is the ad campaign for HPV vaccine. Mom, did you know? Yes, that's a really good example, right? And that's something we could probably talk about a little bit in the Q&A a little bit. Good. So fair appeals are a type of loss frame messages because they emphasize, as Marilyn suggested in her example, they emphasize negative consequences. And because they emphasize those negative consequences, people are more willing than usual to take the risk, whatever it is that you're asking them to do, in order to avoid those negative consequences. But what a lot of people don't know is that in our field, we also advocate making sure that you balance fair with what we call efficacy or confidence, right? So we use the extended parallel process model, EPPM, in order to help us design appropriate fair appeal messages. And what this model does is tell us how to create material that's based on fair appeal, and then it tells us how, in theory, those appeals should be cognitively processed. So we have that material, or what this model calls the stimuli. And in that material, it should include specific message components. It should include efficacy, both self-efficacy and response efficacy. Self-efficacy is I am confident that I can that I can do this, right? And response efficacy is I know that if I do this, it will be effective. To change whatever it is, or to prevent whatever was going to occur in terms of health that's bad. Then the other message component would be threat. You need to include a susceptibility message, and usually that's some kind of data, like 1 in 4 people like you, whatever it is. You could use race or gender, 1 in 4 women, 1 in 4 Asian Americans, right? You could, whatever it is that would help people know that they personally are susceptible, that should be in the message, as well as severity. How severe is not doing this behavior or doing this behavior to your health? Will you die? That is important to say, right? So susceptibility and severity both make up the threat message, and self-efficacy and response efficacy make up the efficacy message. And in theory, you have to have high levels of both threat and efficacy to make sure that people change their behavior. You don't want to have too high threat, because if we have too high threat and not enough efficacy or confidence, people go into fear mode, they go into defensive avoidance, and then they'll reject the message, right? But if there is high threat and high efficacy, then in theory, they should go into protection motivation, and they should accept the message and change their behavior or follow the recommended behavior that we are designing for them. So an example of this was another project that I have slightly related in the Jamaican context, again, sexual and reproductive health for the empowerment of girls and women. And this time we're looking at cervical cancer prevention. And what we realized is that although we are targeting women, we are also targeting girls, right? Because the HPV vaccine is administered usually at around 9 to 11 years old. So in terms of children's environmental health, when thinking about message design, sometimes we also have to think about targeting parents, right? Because parents are the ones with the decision making when it comes to things like taking a vaccine, right? So cervical cancer mortality is also unreasonably high in Jamaica as well. It's 6.6 times higher than Caucasian women in the United States as a basis of comparison. And even if you compare African American women in the United States to Jamaican women in terms of mortality, it's still 2.2 times higher in Jamaica. So it's, and this is one of the most preventable forms of cancer. So we wanted to understand what was the fear and efficacy and threat, right? Based on the theory, what was going on there, right? And we wanted to be able to culturally target appropriately. This is another homogeneous population, so we know targeting would be appropriate and acceptable. What messages would be culturally acceptable? So we use the EPPM to understand that and to understand how culture would affect how fear and threat manifest and inform those messages appropriately that we design. So we had a self-testing kit for HPV, and instead of having a plain box, we added a culturally targeted fear appeal message on the box, right? Based on theory and based on the literature. But we didn't just send it out there and say, here, consume this. We wanted to know if the audience would actually perceive the threat and the efficacy in the messages that we designed based on the literature. So we made sure that health comm scholars thought this was scientifically appropriate in terms of the HPV and related messages. We checked with our community partner on the ground, as well as conducted focus groups to inform, the refinement of our messages. So, for example, in looking at what were Jamaican women's fears, and I'm just dabbling just a little bit in the results, not too deep. The focus group participants were asked to review this initial prototype of a culturally targeted fear appeal self-sampler kit, right, with these messages. And it was called the goodie box. And they were to provide feedback on the look and the feel. And they also shared about how they felt about interacting with their daughters and their beliefs surrounding the HPV vaccine. So they said that the first time they had heard about the HPV vaccine was when the government was rolling it out in high school for girls aged 9 to 11. And they said basically they linked it with sex, right? And they did not see it as necessary and they did not gravitate toward it. So we had very low uptake of the HPV vaccine because of that in Jamaica. From these focus groups, we were also able to understand what would be the most appropriate cultural targeting. So we asked them specific questions and they provided feedback on what were the fears and efficacy beliefs that would affect behavior in uptake of vaccine or in other forms of prevention of cervical cancer, right? So they said they don't want it to affect their sex life or relationship with their spouse. It would be good to include male spouses as champions, that doctors and nurses were still credible sources. Celebrities were influential. They wanted to see attractive women to encourage role modeling. They wanted to see their local language, cultural references, and proverbs, etc. And church-based groups and other groups should be used to deploy this. And so when we gathered that data, we looked again at the theory and we figured out what would be the appropriate messages for the theoretical concepts that were in the EPPM model. So threat, which should include a susceptibility message and a severity message, the efficacy message, which should include self-efficacy and response efficacy, and also building on the fair appeal as well. So even a fair appeal image, which is common in the literature to help push forward the feeling of the threat. We also focused on cultural targeting again to make sure that this was embedded in the local culture. So we thought about using symbols and colors, but not just those surface level aspects of cultural targeting, but also thinking about deep aspects of cultural targeting, like how can we integrate people's values, including religiosity, like how can we represent these deep aspects of culture that also influence people's behavior. So this was what we finalized at the end of our formative research. And this represents the outside of the kit. So on the left, this is the outside of the kit, and we had on the inside insert the right-hand part of the kit. So on the left, in terms of messages, we start off by saying her tagline of, I'm in control of my body and my health, so I check myself. It's easy, it's not painful, you can do it too. This is the self-efficacy message, right? Making sure that they can see themselves and feel confident that they can carry out this behavior. Now, on the inside of the box, we also include statistics and other things to help move things along. So we add the severity message and the susceptibility message, which is part of the threat, right? So you can see about 400 Jamaican women like you will get cervical cancer. That's the susceptibility message. And almost half will die from it. That is the severity message. So you can put them together. Without any screening, you could be next, back to susceptibility, right? We add severity with the image of how HPV progresses to cervical cancer. So that's the threat message again. And we add that you may look and feel healthy for 10 to 15 years, but abnormal cells can turn into cervical cancer. Severity message. No, they thought in the focus groups, they were like, this is too much. This is too strong. Can you add something more? They said, this will scare me. So how about adding HPV is not a death sentence? You can prevent cervical cancer with regular screening tests. That's the response efficacy, right? To say, if you just do this screening, you can, it's effective. It's actually effective to prevent this, right? So the response efficacy message. And the other one, that cervical cancer is the most preventable female cancer if you get regular screening, another response efficacy message. And of course, throughout it, you can see the Jamaican colors, the use of the hibiscus in the background, the representation of the curvy lady, which was very much loved and approved by the local population. They nod to religiosity in her little necklace, right? And then we used local proverbs and sayings as well to add that depth of cultural targeting as well. Prevention better than cure is something a lot of local people say. Take sleep and mark death is another one of the local sayings, that you don't sleep on this, basically. Don't sleep on things because they could turn out into something really bad, right? So we also culturally targeted the instructions for how to use the self-sampler kit, and we directly addressed myths and misconceptions in this messaging. So we said HPV does not affect your sexuality, your vagina, cause cervical cancer. It just detects abnormal cells, because there were so many misconceptions and myths that came out in the focus groups. We wanted to directly address them in the messages. It's not caused by obia, which is kind of like a local version of voodoo. It's not caused by kissing, right? So we went into all of what it is not and what it is. and included that in the instructions, below the instructions as well. And you can see that, so that was, you know, all a part of the kit. And inside the kit, it just includes the self-sampler tool, which you can use in the privacy of your bathroom to swab for abnormal cervical DNA. You put it in that other little vial and take it out. You close the vial, put it in a biospecimen bag, and then you take it to the local clinic, is the idea of it, right? So they were able to also use the kit as well. So we were testing to see uptake of this kind of intervention when messages were culturally appropriate, culturally targeted, and included this fair appeal that included a balance of both threat and efficacy messages. So much more on this can be found beyond. I just shared about the formative work toward the development of this kit and the message design, but you can check out any of these articles for like clinical data, what happened, how many of the participants did have high-risk HPV DNA. And there's another one with a message design experiment where we compared what happened if we had culturally targeted messages versus just a plain box in different communities among about 200 Jamaican women. And we also have a theory paper related to that. So again, to kind of wrap up, I shared two main communication skills for children's environmental health: message targeting or tailoring, which is customizing information to be adapted or to one or more psychological or demographic or behavioral characteristics of the recipient or the population. So targeting, you target homogeneous groups. Tailoring, you're trying to customize messages to subgroups and their values and characteristics, etc. So that's one skill, as well as message framing, which you can use various types of message framing. Today, I talked about using fair appeals, which includes manipulating how information is conveyed in a message, you know, to elicit a certain response that you hope to persuade people to do, to change their behaviors. Both of these skills can be used in children's environmental health to facilitate behavior change in children's environmental health. I hope that was useful. I tried to pull back the curtains a little bit to some of the processes in communication science to inform interventions, and I'm open to questions and comments and feedback.
Thank you so much. That was fantastic. If people just want to unmute themselves, if they have questions or questions in the chat, just let us know. Dr. Chen?
So thanks for really this very interesting and informative talk, about communication. So I have one question about really, children's environmental health is something people worry, but when you communicate with people talking about children's environmental health, they would say, I have to worry about inflation, I worry about all these kind of other issues. So how do we actually communicate the sort of the essence of doing this kind of communication to raise the priority of children's environmental health, say lead exposure, air pollution, asthma triggers, or chemical exposures? This is something I just want to get how to actually make our issues more priority to the people, to the general public.
That's a great question. And I think in the context of message design, it's very challenging because not only are we competing with unhealthy messages and unhealthy environments, but often we're competing with healthy ones too, and other diseases and pandemics that come up. I think many of us who work in this field, for example, when COVID happened, of course, we're very concerned about COVID and children, but also we're concerned about other things and children too. So many other issues, that you mentioned as well. So we have, in the environment of messages, we have to what social marketing talks about is the competition, right? The good and the bad competition of messages and how to find that space. And I don't know that I have an answer. I think that's something that we're still all working on, is how to, because you're mentioning very environmental in terms of the physical environment issues. And I'm talking about sexual and reproductive health, for example, right? And both are important. And so that's very much something that I'm still thinking about and figuring out. And if you have thoughts on it, I would love to know, how can we share space and how can we optimize visibility of these issues without triggering this message fatigue, which we also have to be concerned about.
Yeah, I was thinking of the message fatigue with the same, when you were showing that parallel, that chart of the threats going and making sure the threats do not go into the abandonment of the target. I was thinking about that through the climate change realm, as well as some of these big ones when it comes to what we're hearing in the news of things coming up more about endocrine disruptors. And now, when you see the maps that are happening of, the chemicals are everywhere, it quickly becomes well, I can't do anything about it. The threat has become so big that it's sort of that abandons that message. It goes from, it almost goes from not focusing to immediately I can't do anything about it. Because it becomes so overwhelmed. So you combine that with that same thing of climate, how quickly each one of those topic areas goes to abandonment of the threat because of how big it is.
Yeah, and I was thinking too, I don't come from the environmental health world, but I'm learning more as I'm involved in this project. And so a lot of times the threat in environmental health is unseen and not, something that you can visibly know it's a risk or a threat. And then a lot of times the self-efficacy part of what you can do to solve it is very expensive, or can be, in terms of buying organic food or getting an air purifier, to clean your air in your home. So that seems to be a challenge that we're facing as well in terms of the messaging that goes out, is that sometimes those two things can be a little more complicated.
I was noticing just how well you really did the tailoring of the messaging, and it was, it really, really beautiful. And I'm just thinking about the researcher who's trying to communicate with a population that they don't feel particularly connected with. They may not, they may be a different gender, completely different socioeconomic group. There may be a real disconnect, maybe from a different region of the country. What do you think are the best strategies to gain the insights to allow them to tailor the messaging, to be most effective?
Yes, this is something that comes up in my class that I teach on health disparities. And I say we don't have to share the same ethnic background or culture as people that we want to research. And for me, the ideal way to do any research is really, and oftentimes I should say that even though I am, for example, a Jamaican woman, in this case, studying Jamaican women, oftentimes I'm still an insider outsider. I've left the country. I have a certain power distance based on education and other background factors. So even then, humility is really important in overall approaching research and interacting with populations. But the most important thing is really to approach communities through some kind of facilitator on the ground, right? You want to have somebody that you partner with that can have an entry point and that is trusted within that community to translate messages and to decide on what, for example, interventions should look like and be like. So there was an example that I sometimes share, which I don't even remember where the specific source was, but it was researchers who were Caucasian and went to a particular African context in a rural context in one of the African countries, and they wanted to promote getting rid of bacteria from water through boiling it. And so because they were not having success talking about the biological or the scientific reasons behind doing that, they told the community members that they were boiling out evil spirits, which, yes, it was effective, but it doesn't feel genuine, right? There's some disconnect in terms of like values of how to do things, right? So I asked my students to think about, okay, you got the effect, but was that ethical? So I asked them to think about it, and I'm not judging, but it's just something that for me, it doesn't necessarily sit well with. But another example was a CDC campaign that was related to Ebola. And at the time when that epidemic happened, there was some issues with culture again, and how should we tell people not to touch their families that have deceased or have, or even are alive but are infected? How do we tell people who a part of their culture is to touch, even when dead, a part of honoring the dead is through touch? Well, they went through the local chiefs and had, the chief come up with what is the substitute for touching the dead, right? We have a religious ritual in our particular context. We can't do this anymore due to public health. What can we do differently? And they came up with it, and they came up with a particular thing to do at the funeral. And that came from the other culture. So while there were definitely external communicators and public health people present, they were not visible to the local community. They were there to provide support, to provide scientific knowledge, to help translate it if they could, but they were not visible and on the forefront. So a lot of the times it really takes kind of taking away our kind of ego, approaching things with humility, and working with local leaders to let them implement as best as possible and how they want to do it, whatever the behavior change is.
I have a question about timeline. How long from the design process, making these materials, how many iterations did it take, and testing of the HPV marketing materials? Because that's one of the things that sort of comes up with trying to do these interventions, is really being able to properly test, but also, there's only so much money in budgets and design wise, and how to really make it effective without within limited budgets.
Yes, absolutely. Timing is a big barrier and a big challenge on both sides. Something that I also kind of talk about a lot is community engagement, and how researchers and communities really have different values and different priorities, right? I'm trying to get tenure, for example, right? So I have a timeline. I have a specific thing I want to publish. I know how long it takes to publish something. On the other hand, communities have different priorities. They may not prioritize a particular issue that I'm interested in, but I think is the most salient thing to be studied, right? So there's always this push and pull. And also just culturally, things may move through. There might be bureaucracy on both sides, even within universities, of course, there's a different there's bureaucracy and timeline restrictions, and of course funding restrictions through some of our external funding agencies. They may not understand this kind of science, or it may not be appropriate within the rigidness of our funding mechanisms here. But we've started to get better at that, and we've seen more community engaged projects being funded by the NIH and other agencies, and the science of communication, of community engagement being more recognized. So I'm hoping that we're moving forward in terms of flexible timelines and, appreciating that having a more egalitarian approach with communities, right? A less top-down savior type approach, but a more equal partnership approach does take time. And, this is just one of those things that's a work in progress. There's really no defined solution. We're just seeing things slowly get better in terms of community engagement and the rigidity of timelines and matching those timelines. But it takes constant work on both sides. A lot of dialogue between researchers and communities, and transparency as to what exactly is happening and what both parties need out of the relationship at a given time.